Hello, my name is Eric Fung. I'm the Vice President of Clinical Development at Grail, and I'd like to thank the Prevent Cancer Foundation for giving me the opportunity today to present to you our work in multi-cancer early detection and the way that we are innovating cancer screening via developing a blood-based test for multiple cancers. So this is just a disclosure form. I'd like to begin by telling you a little bit about where Grail came from. We were formed in January of 2016, and we actually arose out of a technology that was examining cell-free nucleic acid in blood for a different reason, non-invasive prenatal testing. But what that technology identified was that we had an opportunity to identify cancer by examining nucleic acid signatures in blood. And we'll talk a little bit later about the biology of this disease. We recently published in 2020 a paper that described this application of the sequencing technology to identify cancer in cell-free nucleic acid. During this time between the inception of Grail and this important paper that we just recently published, the company has grown to be a leader in the field of cell-free nucleic acid analysis and applications to cancer. And the way that we have done that is to assemble a world-class team of clinicians, scientists, bioinformaticists, and other experts, because this is truly an interdisciplinary field that will revolutionize medicine. Our mission is to detect cancer early when it can be cured, and we'll talk a little bit now about the value of early detection of cancer. As many people are aware, many cancers are detected too late, and this graph shows that for 3 types of cancers, which are very common, that the percent of diagnosed cancers for each of these cancers is actually very likely to be metastatic. That is to say that it has spread. And so you can see that, in fact, for both colorectal and lung and bronchus, that the percent of cancers that are diagnosed that are metastatic is more than half. And what we do know is that the treatment of metastatic cancer can be up to 2 times more costly than the treatment of non-metastatic cancer. But more importantly, this has a huge impact on survival. We attempt to diagnose cancer earlier by developing screening technologies. But what we do know is that USPSTF, which recommends various types of cancer screening technologies, only applies to a certain number of cancers. And in fact, the majority of cancers, 79% of cancers, do not have a USPSTF screening recommendation. And so in fact, only a minority of cancers can be screened for today. I'd also like to point out that lung cancer does have a USPSTF recommendation, but that recommendation of low-dose CT is applied to a very high-risk population for lung cancer. And in fact, most lung cancers do not fall within this population. And that leads to a large number of deaths due to the late stage of lung cancer diagnosis that you saw in the previous slide. So we have talked a little bit about the fact that many cancers are detected late and that we have screening recommendations for a minority of lung cancers. If we look at the association with survival, it's very clear that this large number of cancers that we do not screen for leads to a high mortality. And that is because of the fact that most of these cancers are detected late. That is to say that the cancer has spread. So what you see on this graph is on the left, we have 3 cancers, cervical, breast, colorectal, that have USPSTF guidelines for screening. Lung and bronchus, as mentioned just recently, is also recommended for screening, but only in a very high-risk population. And so you can see in this box on the right, that includes lung and bronchus and a number of other cancers, that the majority of cancers that have no or limited screening has a high rate of detection at late stage. And this, of course, leads to poor survival, which you see here. And so we do know that when we have early detection, that we can have a very high chance of survival. And you can see that that is about 89%. but the survival for late stage cancer is only about 21%. And just to focus on lung cancer again, because it does have a screening guideline, but only for individuals at very high risk. And the majority of lung cancers, therefore, are in people who do not meet those USPSTF guidelines for screening. We can see that a much smaller proportion of individuals with lung cancer are detected at early stage. And in fact, the majority are detected later stage, and which leads to a very poor survival for lung cancer. So there are undoubtedly benefits of single cancer screening that we have seen, and that has been particularly true for cancers such as cervical cancer and colorectal cancer. But we do know that any given individual has actually a greater likelihood of having a different cancer from the one that they're being screened for. And that is what this graph shows. So if we look in the red box as an example, an individual going for a colorectal screening per USPSTF guidelines actually has a much greater chance of having a cancer that is not colorectal cancer. And this is true for any single cancer screening. And that's because obviously the total number of cancers outside the single cancer that is being screened for in a specific screening event outnumbers the number of cancers of that screen. And so if we look across each of these cancer types, we can see that the number of non-screened for cancers outnumbers the number of screened for cancers for that specific screening event. And this is one of the limitations of single cancer screening. And this is where we believe that there's a potential benefit for a multi-cancer detection test. And when we describe a multi-cancer early detection test, we really have to think about how that test will be delivered and its value to public health. So there are various elements that are important in the development of such a test. The first is that it needs to be easily deployable. And so we have focused on how to develop this test using a single blood draw. Then there's the technology has to be applied to that sample that allows us to give a readout that is beneficial to clinicians and physicians. We'll talk a little bit later about the biology of multi-cancer detection, but in the middle panel, you can see that we use high-intensity sequencing along with advanced bioinformatics and machine learning to develop an output. And that output on the right is what the physicians act on. And so it's important that we provide meaningful information to physicians. What we do is we first look for a cancer signal. And then if a cancer signal is detected, we provide a predicted localization or tissue of origin information. And this allows a physician to have a more direct line to the type of diagnostic workup they might perform. So as an example, if the cancer signal is detected and the predicted localization is colorectal, the physician knows to perform a directed colorectal examination, for example, a colonoscopy. The deployment of a multi-cancer early detection, therefore, has the opportunity to help physicians and patients identify cancer across a broad spectrum of cancer types, and in doing so, improve the overall survival for cancer. Today, the test is intended to complement guideline-recommended screening, not to replace guideline-recommended screening. It's designed to detect many lethal cancers, including many of the unscreened types from a single blood draw. And if you look at the types of cancers that we detect that are listed in the upper right corner, and this represents only a small proportion of the total number of cancers that we detect, you can see that it includes many cancers that are not detected, that are not screened for, such as esophageal, head and neck, liver, and so forth. One of the important elements of the multi-cancer early detection test is that in widespread deployment of such a test, we have to ensure that we minimize harms to the public health. We'll talk about the different kinds of harms that exist in a screening paradigm, but one of those is that we want to minimize false positives, and this translates into a requirement for a high specificity. The reason that we want to have a high specificity is that every individual who gets a positive result is going to be worked up, and so we want to minimize the number of unnecessary workup when this multi-cancer early detection test is deployed. So in aggregate, the Grails approach to developing multi-cancer early detection tests is to focus on availability, i.e. a single blood draw, accuracy, i.e. a high specificity, and usability, which is to say that we provide a predicted localization to help physicians plan their patient management. In order to achieve this, we really have to leverage an interdisciplinary approach. And as we have developed this technology over the last several years, we have integrated information from bioinformatics, from advanced sequencing, and from machine learning. And leveraging all of this information allows us to create a paradigm that you saw in the previous slide. I mentioned earlier that I would tell you a little bit about the biology of this disease. So cancer is a disease of the genome, and we know that there are a number of different kinds of genomic aberrations that occur in cancer cells. When a cancer cell dies, it can spill its DNA into the circulation. And so what we can do is we can collect the blood and look for those cell-free nucleic acids that come from the cancer cells. What we also know is that when we collect the blood, we actually capture the majority of the cell-free nucleic acid that we capture is from normal cells, i.e. white blood cells and other normal cells that have died and shed their cell-free nucleic acid into the circulation. So the technology challenge, and one of the important elements of the research and development underlying this test development, is in fact the ability to distinguish the cell-free nucleic acid signals from the tumor from those that come from normal cells, because the cell-free nucleic acids that come from the tumor tends to be only a small proportion of the circulating nucleic acid. I mentioned to you that there are many different kinds of aberrations in the nucleic acid of the cancer cells. So the genomes of cancer cells are highly aberrant, and they can have mutations. They can have changes in copy number from the normal 2 copies to many copies, or even loss of copies. And they also have changes in their methylation patterns. We examined all of these different types of aberrations in an early study, and we identified that epigenetic methylation patterns had the power of being able to detect cancer signals, and just as importantly, help us localize those cancer signals to specific tissues of origin. This makes sense from a biological standpoint because methylation is a fundamental signal for cellular differentiation by regulating gene expression. As such, it is obviously altered in the genomes of cancer cells, but it's also altered differently when we look at different cancer types. So the methylation pattern in a liver cancer cell is different from the methylation pattern in a lung cancer cell. And we can leverage this information to help us provide information to physicians as to the likely origin of a cancer, and therefore help the physician direct their workup. So as I mentioned earlier, the fundamental principles in developing a multi-cancer early detection test is to detect a wide spectrum of cancers, and ideally to detect all cancer types. Today, it's meant to complement recommended single cancer screening tests. And we talked a little bit earlier about the strengths and weaknesses of single cancer screening tests. And so therefore, a multi-cancer test can complement those single cancer tests. We want to optimize overall cancer detection. And that implies that we want to ensure that we develop a recognition or machine learning algorithm that's applicable to a broad variety of cancer types. And at the same time, we need to minimize harms. And I mentioned to you one type of harm, which is false positives, and we want to minimize false positives. I'll talk a little bit later about a different kind of harm from cancer screening that we have aimed to minimize as well, called overdiagnosis. So we talked a little bit about the biology of cancer and the development of multi-cancer detection tests. In order to actually develop the test, though, we need to have a robust clinical development program that allows us to develop the test, validate it, and ultimately implement the test. Because screening is a population health approach, we really need to do population scale studies. And so we've designed 4 studies that approach the problem of cancer screening at a population scale. And collectively, we believe this is one of the largest programs exploring cell-free nucleic acid for the purposes of development of an early detection test. We started with a study called CCGA, or the Circulating Cell-Free Genome Atlas study, which comprised more than 15,000 individuals. And this is really the foundational study that allowed us to develop and validate this test. And we'll talk at greater length about this study. We have 2 cohort studies that examine different kinds of screening populations. The first is STRIVE, which is a clinical validation in women undergoing mammography screening. This study has fully enrolled and will be read out shortly. The other cohort study is SUMMIT, which is applied to a high-risk population for lung cancer. And this is also a clinical validation study, and this study is ongoing. We are currently enrolling a study called Pathfinder in the bottom left. Pathfinder is an actual implementation study in which we provide results to physicians, and physicians act on those results. And it allows us to examine how physicians utilize the test and how patients respond to the test by examining patient-reported outcomes. And this study is currently enrolling. So I want to focus predominantly on CCGA because we have recently reported the results of CCGA in Annals of Clinical Oncology. The Circulating Cell-Free Genome Atlas study is an observational case control study. And as I mentioned earlier, the first objective of this study was to really perform discovery of the right types of genomic aberrations to utilize in the development of the test. And so in the early phases of the CCGA study, we explored copy number changes, mutations, and epigenetics. And as I mentioned earlier, we have focused on utilizing epigenetics to train and validate a machine learning classifier that can first differentiate cancer from non-cancer and then predict the localization of that cancer. This study, as I mentioned earlier, encompasses over 15,000 participants with and without cancer from over 140 sites. We collected blood from all of the individuals as well as tissue samples from those with cancer. And we collected a large amount of clinical information to help us do the association between the genomic patterns we see in the blood to their clinical information. One of the most important elements of this study is the follow-up of the participants, both in the cancer and non-cancer arm. This allows us to do long-term association of the baseline blood signal with outcome. And we'll talk a little bit about the importance of having that information as we look at the application of a multi-cancer test into the public health system. So one of the elements that we need to examine is the trade-off between detection of cancer, which is sensitivity, and specificity, which is the assurance that we have a low false positive rate. So we set our test to have a very low false positive rate, as I indicated, less than 1%. And then we looked at what the detection rate was across a variety of different cancers. And what you can see here is that we have high sensitivity for non-metastatic disease or early stage cancers across these different cancer types. I'm not going to go through each of these one by one, but you can see that most of these cancers are cancers that we do not screen for. And therefore, we believe that this has applicability to and will influence and improve the early detection of cancer when widely deployed. One of the elements of cancer screening that has been evaluated is a concept called overdiagnosis. So it is possible to detect cancers, but there are a number of cancers that are quite indolent and that are unlikely to kill an individual. Perhaps the most widely known example of this is prostate cancer, where many older men will develop prostate cancer that will not kill them. And a common saying is that it is a cancer that a man will die with, not a cancer that the man will die from. And so we explored whether the cancer signals that we identified would partition individuals into the more deadly, having the more deadly type of cancer versus the less deadly cancers. And therefore, we could identify the hypothesis of whether our early detection test would be subject to overdiagnosis. These are Kaplan-Meier curves that show survival over time. And so basically, the higher the curve, the better the survival. What you see in purple is the cancers that we do not detect. And what you see in the light blue is the curve for the cancers that we do detect. And what you can see is on a stage-by-stage basis, the cancers we detect are the more aggressive cancers because they have a lower curve than the purple, which are the cancers we do not detect. What this implies is that the cancer signals that we are detecting in cell-free nucleic acids reflect cancers that are more aggressive and therefore need to be treated more aggressively. And so this also supports the concept that we have a paradigm of looking at cell-free nucleic acids that will not contribute to the overdiagnosis issues that we have seen with applications of some other types of screening approaches. So as we summarize the performance of the multi-cancer early detection test, I think we can say that we have achieved many of the goals that we set out to achieve. We said earlier that we needed to be able to detect a broad range of cancers, and we can do that. Positive predictive value is a relationship between sensitivity and false positive rate. And in order to have a good positive predictive value, which is the percent of positive tests that are truly positive, we need to have a very low false positive rate. And you can see that our false positive rate, which we targeted to be less than 1%, is 0.7%. which translates into a positive predictive value of around 40%. And in fact, this is much higher than the positive predictive value of any current screening test that is utilized and recommended by USPSTF. We also have good sensitivity for early stage cancer, that is to say non-metastatic disease, and in fact, even higher sensitivity for those highly lethal cancer types. And then lastly, we also can predict the cancer type, that is the localization of these cancers, with very high accuracy. And the other point that I'd like to make is that the cancers that we do detect, even among the very specific cancer types, tends to be the more aggressive cancers, therefore implying that, that they would benefit from this earlier detection. So we can imagine a world now where we apply a blood-based multi-cancer early detection test into a system that includes single cancer screening. So starting on the left, if we look at what the world looks like today, we have 4 cancers for which there are USPSTF guidelines for screening. And if we look at the application of the current screening paradigm, we can identify 209,000 cases. This comes at a cost of 8.5 million false positives. And so there's obviously a great value for the current screening paradigm, but we do know that we pay a cost to this. The cost, first of all, is in the false positives and all the workup that we need to do to work up all of these individuals to identify those 209,000 true positives. The multi-cancer early detection test that I've described today can identify, and again, this is model data, but could identify 440,000 cancers at the cost of about 740,000 false positives. This reflects the more than 40% positive predictive value I spoke about on the previous slide. The signal to noise ratio, therefore, of this approach is 1 to 1.7, which is, as you can see, substantially better than the signal to noise ratio of single cancer screening. And this translates into a much more efficient cancer diagnosis workup. So when we overlay the blood-based multi-cancer early detection test that we've been developing with the USPSTF guideline recommended screening, you can see that we can detect 650,000 cancers now with only a small increase in the number of total false positives and a much more efficient diagnosis methodology for cancer than just relying on USPSTF guidelines, but just as importantly, a much greater overall number of cancers that are detected. And this, we believe, will translate into an improvement in overall survival from cancer. So in conclusion, I'd like to say that the development of a multi-cancer early detection test has the promise of improving overall outcomes from cancer by allowing us to have a deployable test, that is to say, a blood-based test that can identify a broad range of cancer types at early stage. We do recognize that this changes the paradigm of cancer screening, and consequently, there will be a large amount of education that is required to multiple stakeholders, whether that's physicians, patients, as well as potential healthcare systems and payers and regulators. But we believe that ultimately this will be reflected in improved overall healthcare outcomes for people living with cancer. Thank you, and I appreciate the opportunity to present today.
Hi, everybody. This is Josh Offman. I'm the Chief Medical Officer from Grail. Unfortunately, Erika wasn't able to be here today, so I'm here to take any questions or have a discussion about what you all just heard. Can everybody hear me?
Yes, we can hear you. And we also have a raised hand.
Great.
From Elizabeth, please unmute your microphone so we can hear you. Looks like she lowered her hand. We have a raised hand from Jodian. Please unmute your microphone so we can hear you.
Hello.
Hi there.
Hi. I don't know if I understood the doctor correctly. I thought I heard him say that a colorectal cancer is one of the cancers that's overdiagnosed. And if it is overdiagnosed, shouldn't it still be treated even though the gentleman might not die from it?
So it turns out colorectal cancer is not one of the ones that overdiagnosis is a big concern. Most of those really relate to early stage hormone positive breast cancers and largely prostate cancer and thyroid cancer. So you're exactly right. Colorectal is not one of the cancers that overdiagnosis is a large concern with. And cancers that are detected, obviously, we're very aggressive about treating.
Okay, thank you.
Sure. I think the point he was trying to make in the presentation was that he used colon as an example that when when any individual is going to get a single cancer screening test, like a colon cancer screening test, they're still much more likely to be diagnosed with a different cancer other than colon cancer in their next 2 years because of just the sheer numbers.
Looks like we have a raised hand from Norma. Please unmute your microphone so we can hear you speak.
Yes. Am I right to understand that the multi-cancer early detection tests are now available to all physicians?
Norma, thank you for the question. They're currently investigational, and they're not available commercially. We do think our test, which is the most advanced that we're aware of, will be commercially available probably in the next 9 to 12 months. So we're getting there. We're in, obviously we're in a breakthrough designation with the FDA, and that's going to be a little ways out. But as a lab developed test, our hope, if everything goes well with the completion of one large study that we're doing, is that within the next year we'll have a commercially available test.
Thank you.
Sure.
Right, we have another raised hand from Gopal. Please unmute your microphone so we can hear you ask your question.
This really is a paradigm shift. The question which I have is, what will be the price point for it in terms of vis-a-vis the individual tests? What is the benefit in terms of a ratio for this multi-cancer screening, early detection screening through blood tests vis-a-vis the other ones which are being used one-on-one?
Yeah, so it's a great question, and let me make a couple comments. First, what we're envisioning that this test will be used in populations at elevated risk for cancer. For example, those over the age of 50 have about a 13 times higher incidence of cancer. Cancer survivors, people who have symptoms and are being worked up for cancer. There's many high-risk groups, smokers who are at elevated risk of cancer. And we think initially the test will be used in those elevated risk populations, the Medicare population, and others, diabetics who are at a high risk for cancer. The price, it's premature. We have not set the price for the product, but we do know that as a screening test for population, as an early detection test, that we're going to need to be at very low price points. Most of the genetic tests now that exist for cancer patients are in the many thousands of dollars, and that's not what we are aiming at all, because we know that we need to be able to make the biggest impact on the public health and to bend the curve on cancer mortality, which is soon to become the #1 killer. We need to have this test accessible to as many elevated risk populations as we can in this country, including underserved communities. And because as you all well know, there are some disparities in cancer care that we think our test may be helpful in helping to alleviate over time. So we can tell you that from a value perspective, it will be very good value for money, because the benefits in terms of human health are going to be extremely high. But we don't really know the exact price point right now. And we do think over time the prices will come down, because the cost of sequencing DNA is going to continue to go down. But we do view the test, this will be an annual blood test. That was one of the questions that came up online.
We have another raised hand. Please unmute your microphone so we can hear you ask your question. There you go.
Yeah, can you hear me?
Yes.
Yeah, sir, about this blood-based cancer screening, could it replace for the cervical cancer screening program like pap test and VIA technique?
It's a very important question. So we have designed this test not to replace any of the standard of care screening tests, but more to serve as a complement to them. The standard of care screening tests, which include cervical cancer screening using pap smear and HPV tests, colon cancer screening tests and mammograms, and those are well established with clear mortality benefits. So we think our test can be a nice complement to those, but we're not intending them to replace the existing tests. Now, 5 years from now, when we have an enormous database and a lot more data, could that happen? I wouldn't say never, but that's certainly not the intention of how we're producing the test and how we're going to commercialize it.
Okay, thank you, sir.
We have a raised hand from Erika. Please unmute your microphone so we can hear you ask your question. It looks like we have a question from Terry. Please unmute your microphone so we can hear you ask your question. Terry, you'll have to unmute your own microphone. Okay, we'll move back on to Erika. Erika, please unmute your microphone so we can hear you ask your question.
Hi, this is Erika Bailey in New York City. If we have follow-up questions after this presentation, is there contact info we could reach out to someone directly?
Sure, I'd be happy to have Kelsey or Aaron provide the coordinators with some contact information. I'd be happy to talk about things after the presentation, for sure.
Thank you. And if this is a screening, hopefully, I don't know if it will fall under the header of the Affordable Care Act of preventative screenings, if it's something that's deemed necessary or helpful with it being complimentary. Just curious with affordability and access to care when it comes out to market. Just a thought.
Yeah, no, it's a great question. Right now, these types of tests, multi-cancer early detection tests, will not have any Medicare coverage, given the way Medicare statute's been written. But we're working very hard to find ways of and making sure that this could get covered. There may be non-Medicare plans in the ACA that would consider this as part of their routine annual screening that could get covered through the exchange plans. And that's something we're looking at. Thank you for that suggestion.
Okay, we have a raised hand from Patricia. Please unmute your microphone so we can hear you speak.
Can you hear me?
Yes, hi Patricia.
Hi, thank you so much for having this information presented. It has special interest to me. I am a two-time cancer survivor. I had my first cancer, cervical cancer at 26 years old and breast cancer at 42. And I'm happy and blessed to say that I have survived both to date with no recurrences. My family, I always call a walking oncogene because on my father's side of the family, my father was one of 14, huge family, lots of aunts, uncles, and cousins. And we have breast, ovarian, cervical, pancreatic, and colorectal, and prostate in men, and Hodgkin's. So my first cousin and I were diagnosed 2 weeks apart with our breast cancers. She was early 30s and I was early 40s. Eventually, both been tested. She was positive for BRCA2. I was negative. And I had a full panel done at that time, in which I also was negative for Lynch and other type of, polyposis type colorectal cancers. But I was told that I had some type of aberration in the colorectal area that is non-specific, and they don't know if it's something that turns on or blocks, and that more information would be coming in the future. Stay tuned. As they learned more, they would be able to provide more information. This test that you are working on, would that be able to differentiate that more specifically?
Yeah, Patricia, it's a great question. If you're talking about a finding in the colon that was an anatomic finding that is that they're asking, or you're talking about more of a genetic finding?
Yes, it was on this panel, this genetic test for multiple cancers.
Yeah. So probably not. I think what those tests are trying to do is look at your genetic makeup to understand your risk of developing cancer, right? And
okay, yes, you're probably right. Mm-hmm.
There are some genes that are clear, like BRCA and others, where it confers a much higher risk of developing cancer. And then there's some genes where we think those genetic mutations do have an elevated risk of cancer, but we don't have a huge amount of evidence. What our test, the Grail test, is doing is actually looking in your body, in the blood, and looking at your DNA and seeing whether there's a signal for cancer right now. In other words, do you have a cancer in your body now? Mm-hmm. If we find a signal, our test is able to localize that signal to a specific tissue or organ. And so it's not a risk test like those like 23andMe.
Yes, I get
Yeah, it's an early cancer.
Yeah, it's diagnostic. It's more diagnostic. Okay. So as far as it would be a great overall type of test for multiple types of cancers. But for somebody who's high risk for colon like me, because I have a first degree relatives, it's not going to replace the colonoscopy or me doing my colonoscopies. I should
you should continue doing your colonoscopies if you're at high risk. I would suggest that for people, when this test is available, for people at high risk like yourself, adding the Grail test could be very helpful, because you could, colonoscopies, I think they don't like to do them every year. You could possibly, over time, combine with the Grail test to extend procedures.
Exactly. Thank you so much. I'm very excited about this for the future of cancer care.
Story. What a hero you are for surviving two or more cancers. Amazing. That's fantastic.
All right, in order to respect everyone's time, that was our last question. Thank you so much to our sponsor, Grail.
Thank you, everybody, very much. It's been an absolute pleasure being here, and we very much appreciate what you're all doing. So thank you.